Good morning, everybody, and thank you so much for joining us for this webinar on the healthcare block exemption. We've got a great panel that's going to be discussing a number of issues arising from the healthcare block exemption. And we are going to be starting with Bukosi Bakemajenge, who I'll introduce to you in a moment. So my name is Nandi Mokwena. I'm with the Competition Commission. We are going to start now with Bukosi Bakemajenge. If I can just take you through his profile, just so you have a better idea of who he is and what expertise he brings. He's the moderator of our session today, and Mr. Majenge is the Competition Commission's Chief Legal Counsel. He's the acting Deputy Commissioner as well. He's worked for the Commission now for a cumulative period of more than 7 years, having joined the Commission as the Head of Corporate Compliance in 2008. He was subsequently appointed Principal Legal Counsel in 2009, and he's been Acting Manager of the Legal Services Division since September 2014 until his appointment. Mr. Majenge was admitted as an attorney in 2000, and he has a BProc and LLM from Fort Hare and the University of South Africa, respectively. So he'll be taking you through the very next session, and he will be providing us an overview of the healthcare block exemption. You can expect to hear from him what it's about and what the purpose of the block exemption has been. So I need to first tell you how you get to participate in this webinar. You can ask questions. You'll see that we've enabled a Q&A section. So you just get to post your questions online, and we will go through your questions towards the end of the session. We'll have about half an hour to go through all of your questions. And so we're hoping that this will be interactive in that way. Although you cannot ask them verbally, you can type them out in the Q&A section. The one thing I do need to do is apologize for this late start. We're having some technical difficulties, but I believe that those are sorted now, and we're ready to go ahead with the panel discussion. Before I ask Bake to give us the overview, we thought that in this audience, it's appropriate to remember the healthcare practitioners that have been fighting a fierce battle on the front lines of the COVID-19 crisis. I have some personal experience in this regard, and I can tell you that this is not a battle that the healthcare practitioners signed up for, yet they get up every day and they go out there to save lives. I wondered if we could please just observe 30 seconds of silence for all of the healthcare practitioners that have passed on, sadly and unfortunately, in this COVID-19 crisis. 30 seconds, please. Thank you very much for that. Bake, I'm going to hand over to you now for you to give us an overview of the healthcare block exemption. Thank you.
Yeah, morning everyone, and thank you very much, Nandi. I have prepared a slide presentation which I'll request Iteboheng to put up. Yeah, thank you, Iteboheng. I'm not going to go through each and every slide. I'm just going to present some of the key slides. which summarizes the issues. Next slide, please, Itebuchen. By way of an introduction, the healthcare block exemption fetches its origin from the Competition Amendment Act, which was signed into law by the President in 2018. So even though at the time the Competition Act was amended, the crisis was not foreseen at that time. But interestingly, these amendments to the Competition Act have actually enabled the competition authorities to respond quite swiftly to the crisis. So the exemption was done in terms of Section 1010 of the Competition Amendment Act, which allows the Minister of the TTIC, after consultation with the Commission, to grant a block exemption. Next slide, please. So the Amendment Act allows the Minister to gazette regulations in order to give effect to purposes of the Act. So in response to the declaration of COVID-19 as a national disaster, the Commission assisted the Minister in granting a couple of block exemptions, and those include the healthcare sector block exemption, the banking sector block exemption, the retail property industry block exemption, as well as the hotel industry block exemption. So what these exemptions effectively do is to enable these sectors to collaborate and to coordinate in response to the crisis. Ordinarily, such kind of collaboration or coordination would have fallen foul of the cartel provisions of the Act. So the health sector block exemption was gazetted by the Minister at the request of the Hospital Association of South Africa, and that request was made on 17 March early this year. We all know who the members of the Hospital Association of South Africa are, and they are reflected in the presentation. According to the Hospital Association of South Africa, the exemption was critical to assisting the sector to respond to the emergency and to put in place a rapid as well as an effective response to the crisis. Next slide, please. In its application for an exemption, the Hospital Association of South Africa, of course, referenced certain rights, certain constitutional rights, which are implicated in motivating for the need for the exemption. So essentially what they sought through the exemption is that HASA members should be permitted to collaborate significantly with each other in order to maximize the effective usage of the existing capacity within the hospitals in response to the pandemic. Next slide, please. So the specific areas that the Hospital Association of South Africa sought an exemption on included coordination on ensuring that patients are allocated between the hospitals in the most efficient manner possible, being able to communicate with each other in relation to capacities, as well as utilization of facilities, being able to coordinate on specific types of services, medical professionals, nurses, as between various hospitals. Next slide. They also requested an exemptions on being able to transfer resources, nurses, medical practitioners from one hospital to the other, and being able to coordinate on the procurement of various consumables, pharmaceuticals, as well as various inputs which would be required for the treatment of patients. Next slide. HASA also identified the need for collaboration on financial matters related to the treatment of patients referred from other hospitals or from the public sector. Next slide. I think we can jump the next two slides, slide 9 and 10. We can jump. And in fact, the block exemption, which was granted by the minister, as you can see, the exemption was requested on 17 March, and 2 days later, the minister gazetted the exemption. So that speaks to the responsiveness of the minister, as well as the responsiveness of the amendments. So you will see from the categories of agreements of practices which are exempted that in fact the minister, the exemption, the scope of the exemption granted by the minister was both responsive to the request from the Hospital Association of South Africa, but also went beyond what was requested by HASA. In relation to hospitals as well as healthcare facilities, the exemptions covers collaboration between hospitals on the allocation of patients, professionals, equipment, services, as well as communicating on capacity, the procurement of drugs, consumables, and the like. So in relation to medical suppliers, the exemption allows suppliers to communicate on availability of supplies, as well as, more importantly, to coordinate the procurement as well as the distribution of medical supplies. Next slide. In respect of medical specialists as well as radiologists, as you can see, the exemption is broader than what the Hospital Association of South Africa had requested. So it allows medical specialists as well as radiologists to share data on the scale of the outbreak, the disease patient profile, as well as capacity utilization, as well as any agreement to standardize care protocols, as well as transferring supplies or resources. In respect of pathologists, The exemptions allows pathologists to communicate on capacities, utilization, and it also allows them to coordinate their procurement of input required for testing, as well as to transfer supplies as well as equipment. In respect of pharmacies, the exemption allows pharmacists to communicate on availability of pharmaceuticals, medical consumables, as well as coordinating on the transfer of consumables, of pharmaceuticals, as well as to coordinate on procurement. In respect of healthcare funders, the exemption allows healthcare funders to agree on the reduction of costs for diagnosis, tests, treatment, as well as other preventative measures, and to reach agreements with healthcare facilities to reduce those costs. So the exemptions allow some form of collective bargaining between healthcare funders as well as healthcare facilities for the purposes of reducing costs. Next slide. Now, there was an important proviso in the exemption that the agreements or collaboration which is exempted will only be exempted if it's undertaken in coordination with the Department of Health. So the scheme of the exemption was to place the Department of Health at the center of all these arrangements, because these were arrangements that are in response to the COVID-19 pandemic. The exemption also allows coordination on prices. If that coordination on prices is authorized by the Department of Health, so that also underscores the centrality of the Department of Health in the scheme of the exemption. We can move to the next slide after purpose. The exemption was further expanded by the minister to allow competing manufacturers as well as suppliers of medical and hygiene goods and services, such as hand hygiene, water sanitation, ethicals, and so on, to communicate with each other in relation to stock availability, and more importantly, to coordinate on the procurement as well as the distribution of those goods as well as services. So what government has sought to do through the exemption was to really put in place an enabling framework to enable the healthcare sector to collaborate its response to the pandemic without being constrained by competition laws, in particular the anti-cartel provisions of the Act. Thank you very much, Nandi. That then brings us to the end of the presentation. I will then ask Nandi to then introduce our panelists. Nandi, I think you're on mute.
Sorry. Thank you. Thank you, Bake, for that very informative overview. As Bake said, I'm going to now introduce to you the panel that we have. We're launching into a panel discussion. It's going to be moderated by Bake, who has just taken you through an overview of the healthcare block exemptions. Let me introduce to you who we have on the panel. We have a representative from the Department of Health, Dr. Anban Pillay, who many of you will be familiar with. Dr. Pillay is the Deputy Director General, Health Regulation and Compliance at the National Department of Health in South Africa. I'm not certain if Ms. Melanie da Costa has now arrived on the call, but let me give you her profile. Melanie da Costa is the immediate past chair of the Hospital Association of South Africa, and she's the Director of Strategy and Health Policy at Netcare. She has a background in the investment industry as a stockbroking healthcare analyst, as a fund manager investing in global and local healthcare and information technology assets, and as head of research for multinational stockbroker HSBC. She sits on the Netcare Executive Committee. Then we have Mrs. Lucas, Ms. Monica Lucas. She is a board member and chairperson of the South African Medical Technology Industry Association in the Market Access Committee. Dr. Rajesh Patel is currently the head of Benefits and Risk Department at the Board of Healthcare Funders. Before that, he worked as a family physician from 1987 until 1995. After leaving private practice, he joined the medical aid industry. His roles in the industry cover medical advisor, scheme manager, and clinical risk manager. Then we have three more panelists. Jackie Mayman. Ms. Jackie is the Chief Executive Officer of the Independent Community Pharmacy Association. She was a founding director of ICPA and then became its CEO in 2012 for 2 years. Jackie is very involved in the pharmacy world. She's an EXCO member of the CWP branch of the Pharmaceutical Society of Southern Africa and of Community Pharmacies, the SAACP. She's an elected member of the South African Pharmacy Council, and she's currently chairperson of the practicing committee. Then we have Dr. Angelique Kutsia. She is the national chairperson of the South African Medical Association. She's a medical professional and she holds BMed Sciences, MBCHB, HC Advanced Health Management from Yale, an HC in Criminal Forensic Investigations, and Dr. Angelique is also an accredited mediator. We do have a representative also from the Department of Trade, Industry and Competition. He may not take part in the actual panel discussion, but he is in the audience and he is available to take part should that be required. Dr. Molefe Pule, he is the Chief Director at the Department of Trade and Industry and Competition. He's responsible for managing strategic projects. He's held various other positions, including Chief of Staff at the former Department of Economic Development and Senior Lecturer at the University of Witwatersrand. He obtained a PhD in psychology. This is the very illustrious panel that's going to be discussing the healthcare block exemption with Bukosibake Majenge, and he will moderate the session. Let me just repeat how you get to participate in the session. We have a Q&A that's been enabled so that you can ask your questions. Please, if possible, could you put your name so that we know where the question is coming from? And if you have a particular person that you're wanting to direct your question to, please say so that we can direct it accordingly. We are going to go through the Q&As after the panel discussion has been completed. And with that, I think I'll hand over to Bukosimake to moderate the session. Thank you.
Yeah, thank you very much, Nandi. We will first start by affording our panelists 3 minutes each to just provide their initial reaction to the effectiveness of the block exemption. We will first start with Dr. Pillay to just reflect on whether the exemption, the block exemption, has been useful and whether it has been of assistance in enabling the sector together with the department to respond to the pandemic. Dr. Pillay, 3 minutes.
Thank you, Chair and colleagues from the Competition Commission. Thanks for this opportunity. COVID-19 has presented us with a very unique challenge in that it affected a number of sectors, and within the health sector itself, it placed an extraordinary strain on human resources, on consumables, on medicines, on every aspect of the health system. And I think it's fair to say if there were any fractures in the or fissures in the health system, those would become massive, gaping craters in any system. And I think you have seen over time many of these challenges being exposed in the South African system, as well as in other countries as well. Coming specifically to the exemption, I think that the exemption was supported by the National Department simply because in the supply of many of these commodities, it was important that the providers are able to share information in order to ensure that there is sustainable supply of these resources. In the case of hospitals, I think their provision of services was critical, and for them to be able to discuss how they coordinate between each other, movement of staff, equipment, and the like, it was critical that there was a level of collaboration. We also supported the idea that we were able to engage on issues of price, and that we would collectively bring together the various players and ask them to share their pricing. The way it ended up was we actually did some costing and shared that with the group, and after much discussion and deliberation, we got some agreement around that. And I think that does augur well for future engagements on these issues, and so I think we've done well thus far. We unfortunately or fortunately didn't actually need to procure the extent of the resources that we anticipated. So we didn't buy as many hospital beds as we had initially planned. We anticipated many more patients being hospitalized and the public sector not being able to cope, etc. That didn't actually materialize to that extent. So it's good news from a patient perspective. And our planning, I think, was for a worst case scenario as such. Unfortunately, that didn't come to bear. So I think overall the exemption has worked fairly well in offering us an opportunity to engage with providers in the private sector to deliver services and goods in a manner that doesn't lead to shortages. Remember that many of these requests were made at a point in time when we had shortages of sanitizers and other equipment, and we were staring down a very bleak outlook if we didn't allow the providers to collaborate and ease the problem. And I think to a large extent, many of the challenges were alleviated. Thank you. I think I've used up my 3 minutes.
Thank you very much, Dr. Pillay. I'm not sure whether Melanie has managed to join us, Nandi.
But Melanie hasn't managed yet. I must apologize for this to our audience. We are going to keep trying to get both Melanie and Jackie, who's from the ICPA.
Thank you. I think we'll then move to Monica to give a reaction, initial reaction. on the block exemption. Monica?
Thanks, Mikey. Can you hear me?
Yes, I can hear you.
Fantastic.
Monica.
Super. So thank you very much for inviting SAMED to be part of this very important webinar. I think the concept behind the health exemption was a very noble intent. Just to give a little bit of background, SAMED itself is a voluntary not-for-gain industry association. Our members are a mix of multinationals, local manufacturers, distributors, and wholesalers of medical devices and in vitro diagnostics. There are over 350,000 different medical technologies in South Africa, and they range from simple plasters, masks, to diagnostic test kits, and to highly sophisticated devices like CT scanners, pacemakers, that kind of thing. We provide our members a collective, objective, and credible platform to engage with all stakeholders. When joining SAMED, all members sign up to the adherence of a medical device code of ethical marketing and business practice. And our mission is to ensure a sustainable and ethical medical technology industry in South Africa. In regards to specifically the block exemption, COVID propelled the medical technology industry to the forefront of dealing with the pandemic. It demonstrated the imperative of having a reliable supply of safe, effective, and locally relevant medical technologies. When the block exemption was announced, we, as SAMED, did alert all our members to the exemption and the subsequent amendments when they were originally announced. When we were asked to join the panel, we actually sent a survey out to our members to obtain the results to find out how many of them had actually were aware of the exemption, had actually participated in the exemption. And majority of the respondents were aware of the exemption, but none of them made use of the exemption for various reasons. Such as there were concerns regarding how to actually implement the exemption, how to utilize it effectively. The feeling was the block was not really applicable due to regulatory barriers that blocked suppliers in any event from competing. Non-healthcare companies were coming to the fore, companies that had not been regulated had not gone through the regulatory process with SAPRA. And there were various concerns as to how they were actually going to apply that. So I think from the medical technology suppliers perspective, I think it was quite an interesting non-application of an exemption which potentially had very good far-reaching abilities.
Yeah, thank you very much, Monica. I think we will, of course, have some questions for you when we get to that stage. Dr. Patel? Dr. Patel, I'm not sure whether you can hear me.
Sorry, I was talking to myself there, but schizophrenic. Sorry about that. No, I'd like to commend HASA and the Competition Commission Minister for releasing this block exemption. We really appreciate it. We saw this as an opportunity as one of the first steps to start to implement the health market inquiry recommendation. So we were fully supportive of it. Just to give you some examples of the problems faced in the environment that needed solutions, one of the most critical things was the teleconsultation pricing. Even though we had teleconsult pricing in the medical practitioner database of 2006, there was big discrepancies between what the providers felt they needed for the consultation versus what the funders believed they had to pay towards it. There was a big issue about PPE pricing, which added to the practice bottom line as well. And obviously from the hospital side, they introduced this pre-admission testing, which was not based on any guideline published in the country, and that needed to be sorted out. And there was also the issue of doing electives in an environment where you had an epidemic, and we obviously needed to have this resolved. Most of this would have been ideally resolved if Department of Health had provided the stewardship, particularly on the pricing issues that we had available in this regulation. Unfortunately, we knew Department of Health had their hands full dealing with the COVID epidemic. And it's on that basis we approached the Council for Medical Schemes so that they could take up this challenge and be the minister's right arm and the Department of Health's arm to deal with this issue in the private sector. That was all in April. We're now in August and we still have to wait for a reply. Nothing has come through. Importantly is one of the great things of this exemption allowed the pathologists to get together and drop their prices for pathology tests from 1,000 rand, 1,400 all the way to 850. And they still claim that, this was the best price. They're not making a markup on it. Just to give you a sense, there was another provider via Gift of the Givers, a private practice lab working with Gift of the Givers, making the testing available at 650 rand. And BHF was working with them and got them in touch with schemes such as GEMS, PolMed, who had members working at the co-front of this COVID-19, and definitely got the two parties together to be able to deliver, to do the testing, etc., at this affordable prices at that stage. I think it is unfortunate that from a private funding side, we didn't fully exploit the opportunities available, and perhaps we need to, the COVID is not over yet. There's still a long way to go, and we hope the Department of Health and the CMS comes to the party and allows the industry to be able to engage a lot more in alternate reimbursement modeling and pricing, but also in resolving a whole lot of other issues that we still need to deal with at the industry level. Thanks a lot.
Thank you very much, Dr. Patel. I'm not sure whether Jackie has been able to join us, Nandi.
I'm checking back here, and it looks like Jackie has still not been able to join us. We are trying to make a connection with Melanie, and I believe Melanie is now on the line for you to speak with. Let me reintroduce Melanie just for a moment so that our audience knows who we are speaking about. Melanie da Costa is the immediate past chair of the Hospital Association of South Africa and Director of Strategy and Health Policy at Netcare. She has a background in the investment industry as a stockbroking healthcare analyst, as a fund manager investing in global and local healthcare and information technology assets, and as head of research for multinational stockbroker HSBC. She sits on the Netcare Executive Committee. I'm hoping that Melanie can hear us. Can I hand over to you, Bakhe, so that you can address her directly?
Yeah, thank you, Nandi. Melanie, can you hear us?
Okay, Bakhe, I don't hear Melanie responding. Won't you move over to the next panel member? And we'll continue to try with Melanie.
Yeah, that's fine. We will then move on to Dr. Angelique Coetzee. 3 minutes, Dr. Coetzee.
I do not hear Dr. Coetzee either. Let me just try once more. Melanie, are you able to hear us? I hear a response coming through. Is this Melanie?
Yes, is this clear?
This is clear. Thank you, Melanie. We have Vukosi Bakhe Majenge is going to address you. Thank you.
Thank you, appreciate it.
Yeah, thank you very much, Melanie, for joining us. Apologies about the technical glitches. Melanie, we will give you 3 minutes just to provide a reaction from the perspective of the Hospital Association of South Africa on whether the block exemption on healthcare has been useful. And whether there's anything that could be done to enhance it. Over to you, Melanie.
Thank you, and sincere apologies on my side for all of the glitches and for the noises in Sandton. And it's a pity you can't see me, because you would see me in the nice attire that we wore this morning as Netcare head office went out into the parking lot and did the Jerusalem and saluted all the healthcare workers on the front line. And it was in the spirit in which the session was opened. So when we saw what was playing out internationally, we understood that it needed to be an all hands on deck. And I think if South Africans are able to achieve one thing, that is we are able to rally in times of need. So on the 17th of March, we applied for this block exemption. We also, it just so happened, it coincided with certain other meetings, but we were able to have a face-to-face time with the President Cyril Ramaphosa and Minister Ibrahim Patel. We let them know that this request for an exemption was forthcoming, and by the 19th of March, it had been granted. That's how quick the turnaround was. So, the reason why we wanted to do that is we understood that we needed to put South Africans first. So access to healthcare was so critical, but also we needed to ensure the safety of patients and the safety of healthcare workers. And then the critical element, which was negotiating or engaging with government. How do we ensure that they have a full view to all of the assets in the country, to all of the healthcare workers, the beds, and even daily occupancies, across the various provinces. And that was really what we set out to do. Now, depending on the individual provinces, there was capacity for individual groups to deal with the provinces in terms of the assets in those individual provinces, but at times it was important to actually put a national footprint forward. So what we did is initially what we created was just kind of like a spreadsheet of all of the capacity in the private sector, but then eventually we were able to launch a live database with occupancies that were updated every few hours, just to show where there was capacity for COVID patients, and in case someone in the public sector also needed that capacity. But we also had to share a significant amount of information with respect to the COVID positive patients. If you recall, at the outset of this pandemic, the prevalence appeared to be more in the private sector than in the public sector, and that information sharing through to the NICD and then through to the provinces and to the national was absolutely critical. We also needed to provide all workforce data, so we can get into the level detail on that, but I think what counts is, we had to show a national force to ensure that we're able to address this pandemic. And in the Q&A, we can also take some questions with respect to the provincial engagements that happened. But in the interest of time, I'll leave that to the Q&As. Thank you.
Thank you very much, Melanie. Dr. Pule, I'm not sure whether you would like to weigh in at this stage, because everything will not have been possible if the DTIC had not responded promptly to the request by the Hospital Association of South Africa for the exemption. Dr. Pule?
Bake, I'm told Dr. Pule is not yet here, so I think should he join us later, then we can ask him for his inputs, but at the moment Dr. Pule is not yet here.
Yeah, thank you very much, Nandi. I will start with Monica, because she has indicated that according to the survey that they conducted amongst their members, although the majority of their members were aware of the exemption, but it does not appear that their members have made use of the block exemption, and it appears that there were also concerns around how to go about the implementation of the block exemption. And then my question then to you, in the light of that, Monica, is whether there was no need for some form of collaboration between your members in response to the pandemic?
Thanks, Bake. So I do think that, as I said, I think the intention behind the exemption was exceedingly noble and very commendable on the fast response time from the minister and the department. I think the feedback that we've received from our members is that there was significant concern regarding what the exemption could potentially lead to. Majority of our members that came back to us stated that there were concerns regarding the application of the exemption and that it could potentially lead to corrupt practices if it wasn't utilized and applied properly. Having said that, SAMED did we did take part in the Business for South Africa process, which did allow for some of our members to participate to create a single online portal where SAMED members and suppliers of other COVID response products and services could log their information and make it easier for government and other key decision makers to plan and manage various aspects towards the national response. And having said that, the exemption, and I think it's very critical, the wording that these exemptions utilize, which from a technical perspective, where the exemption did specify that any communication between competitors would have to be under directive given from the Department of Health, and I think there was a lot of uncertainty regarding what does that actually entail. Where do those communications come from? What would they look like? If competitors wanted to discuss stock availabilities and logistics challenges, would they need to secure a directive from the department or from the minister himself in that regard? So I think from our perspective, this could have had a great deal of a potentially good impact on the sector. But I think going forward for future exemptions, should they become apparent, is that there may need to be a little bit more information given to participants within the industry who may need to have those communications clarified for them so that they can be applied so that they are as effective as they are intended to be.
Yeah, thank you, Monica, for those constructive observations. If we could then move on to you, Dr. Pillay. You have indicated that the exemption has enabled engagements on pricing. If you could shed more light on the nature of those engagements and what you were able to achieve in those pricing engagements.
Our primary engagements around pricing have been in the hospital sector as well as in the laboratory sector, but let me talk about our work with the private hospitals. We were able to engage with them around the cost of various hospital services, particularly ICU, high care, as well as general wards. And we took the approach of trying to understand what the cost inputs were from the public sector, as well as understanding what the costs are for the private sector, given that there is a disparity in costs, input costs for the private and public. And we managed to get to some consensus on that allowed us to agree on tariffs that all of the members of the HASA group, for example, would then be able to use as a basis to contract with the provincial departments of health. And I think that that required a fair bit of technical work. We've never done this before, and I think it's a good forerunner to how we would hopefully engage going forward, particularly as we plan towards the national health insurance. In the case of the pathology groups, I think here, the National Health Laboratory Services covers the public health system, and a range of private laboratories are available, and these larger groups came together as the National Pathology Group, and it was good to see that the NHLS could draw on these private pathology groups to take on some of the volume of testing that was required. And you would have seen in some cases that the pathology groups were doing more tests on some days than the NHLS, which was really useful. And we were even able to negotiate around pricing with the pathology groups, and that reduced the cost quite significantly. We were able to contract the pathology groups where that was necessary. So I think all around generally a good story in terms of the exemption and our ability to work with the groups. I think it required the exemption plus goodwill on the side of both the public and private sectors to get together, and that all came together very nicely. Thanks.
Yeah, thank you for those observations. If we could then move on to Dr. Patel. You mentioned that the framework provided by the exemption has enabled pathologists to also get together on pricing and to achieve relatively affordable pricing for testing. If you could just shed more light on that collaboration on pricing and how the exemption has supported that.
I think from our side, we weren't involved in that process, but initially when the private laboratories came up, they each had different prices. One laboratory had about 1,000 Rand, and two of the big ones had about 1,400 Rand that they were charging. And I guess when they were allowed to get together and negotiate their own price and standardize pricing in the country, which is obviously the way we need to go, they came up with 850 Rand. Obviously, they said that was a no markup for type of pricing, and that's what they're doing for the country, etc. We obviously were supportive that effect it came down from 1,000 to 1,400 Rand down to 850, and that's a big saving for anybody. But on the other hand, Gift of the Givers, working with another private laboratory, was able to provide it at 650. That indicated that there is a gap out there and potential further price reductions that could have been achieved. And had there been a framework available for funders to be able to sit down with providers, I'm sure we would have found something more appropriate kind of thing, even if it might have been something in between. So yes, there was some good price reduction by allowing the pathologists to get together, but I think we missed an opportunity to be able to save the public a lot more money, potentially in the region of 200 to another 400 million Rand could have been saved if CMS, for example, was allowed to be the Department of Health's right-hand person and to be able to oversee further funder pathologists' engagement in this regard. So yes, I don't think it's still the end of the world. I think if Anbinson seeing you here, maybe if you could facilitate that for us, I'm sure we can get together with the pathologists and try to act more proactively for further testing.
Yeah, thank you very much, Dr. Patel. Melanie, if you could just reflect on the tariff discussions that Dr. Pillay referenced, and how that, from your perspective, has been beneficial, because Dr. Pillay is suggesting that those discussions could actually, or the model that was used there, could actually serve as a blueprint going forward in the implementation of the national the scheme to provide affordable healthcare going forward. Melanie?
To respond. So there were two elements to the engagement around treating state patients. The one was the SLAs with the provinces, and that was separate from the engagement on pricing, which was set at a national level. So I think it's important to say that it wasn't a negotiation per se, it was a price determined at national. But at the same time, we were able to bilaterally, individually give feedback into the team holding that discussion. So you must just note that the price that was tabled was, we'd like to say not for profit, but it was slightly negative, so slightly loss making, but we did it in the spirit of what was required here. I think that in terms of the lessons for NHI, I think there were a lot of lessons on the SLA more in terms of things like the referral process, the integration of knowledge on the capacity in the system. I think that's where the true learning is. I think that in terms of the pricing, that was effectively set. It was dictated at a national level. It wasn't a collective negotiation per se. It was bilaterally we were able to feed in relevant information and give evidence as to how it was a not-for-profit or situation. So it wouldn't be sustainable necessarily under an well, it wouldn't be sustainable under an NHI, but certainly the learning has been really fantastic. There's been really good collaboration across the board.
Thank you for that response. Baki, I'm sorry to interject. I would just like to let you know that Jackie is now on the line and she's ready to give her opening thoughts. If I may just introduce Jackie again. Jackie Mayman is the Chief Executive Officer of the Independent Community Pharmacy Association. She was a founding director of ICPA and then became CEO in 2012 for 2 years. She's very involved in the pharmacy world. Can I hand over to you, Baki and Jackie?
Yeah, thank you very much, Nandi. Jackie, if you could just in 3 minutes just provide an overview of how the exemption has worked or has not worked from your perspective. Thank you.
Thanks, and sorry about the technical. Hi there to everybody. So I think for ICPA, and we're an association of 1,200 community pharmacies, what the exemption allowed us to do was to communicate with an association such as Plaza to identify potential stock shortages or outages across all the distributors and wholesalers. This was critical regarding medicines such as flu vaccines, cold and flu meds, respiratory medicines. Now, noting the spike in demand in March, just prior to and immediately after a hard lockdown, ICPA, together with the PSSA and corporate chain pharmacies, issued a communique to all community pharmacies to limit supplies of these identified essential medicines and to interrogate requests for medicines such as chloroquine, which at the time everybody was stockpiling. The Statutory Council then followed suit with publications reminding pharmacists of the rules around the supply of medicines such as chloroquine. This collaboration did not involve any discussions of price, but all rather was to reduce the possibility of panic buying and stockpiling by individuals. This initiative was very successful and allowed the medicine supply chain to remain stable throughout lockdown with very few interruptions in supply. The block exemption also allowed a coordinated response to medicine supply challenges. So competitors, we worked together to try and prevent stockouts and to better distribute essential medicines. There was still, however, some maldistribution, especially when it came to flu vaccines. where the bulk of the initial stock was channeled by corporate-owned wholesalers to their own stores and to the exclusion of independent community pharmacies. And this left many vulnerable patients in remote areas without vaccine coverage, as the corporate pharmacies operate mostly in shopping malls and urban areas. This was reported to the Minister and the Competition Commission, and the Minister's instituted an inquiry, the results of which we're still waiting for. But I think the main thing for us, this exemption, and what it proved, is that we can all work together. And by collaborating, we had a more transparent supply chain, and we were able to go through this difficult period with a stable supply chain. We didn't have huge stockouts or stockpiling. Thanks.
Yeah, thank you. Thank you very much for those observations. I hope we're still doing well on time, Nandi.
You are, Bakir, we'll give you an indication when time is running out. Thank you.
Yeah, if we could then move on to the next line of inquiry. And it really follows from what Dr. Pillay, the observations made by Dr. Pillay. And the question is, and I will start with Dr. Pillay, who has raised this issue. The question is whether going forward, there is a need for collaboration in the sector, even beyond COVID-19. Dr. Pillay, I'll start with you.
Thank you. No, I certainly think that there is an opportunity for collaboration. I think that history has taught us some lessons. I think that simply opening up collaboration in an unregulated manner has a number of risks. And I think we're aware of those risks, and the Competition Commission was very much involved with many of those transgressions. But at the same time, we in the recent past, as COVID has taught us, there is an opportunity for us to work together. So I think it's not all bad and it's not all good, but I think we need a defined environment around which the regulatory space will still operate, that allows government to engage with the private sector in the interest of the public good. I think is probably the key objective that we need to pursue. And I think we must, over time, define how that can happen, create the environment for that to happen, monitor that, I think, and at the same time create the space around that is regulated in the manner that we have. And I think little pilots or projects like this provide valuable learning, and we can maybe take a stepwise approach towards that. Thanks. Sorry, you're muted, I think, Chair.
Oh, thank you, Dr. Pillay. Melanie, Dr. Pillay has referenced the concept of regulated collaboration and defining or demarcating areas of collaboration within the sector beyond COVID-19. Do you think that there is a need for such regulated collaboration, of course, within certain defined parameters?
Support what Dr. Pillay has stated with respect to the value of collaboration going forward. You know, if we look at this period over the last few months, there have been so many pressure points in the public system, specific, for example, to maternity. You know, on our side, we were just hearing of some desperate pleas for assistance from patients that were struggling, you know, in maternity. And if we reflect on NHI, I do think that if there was a piecemeal approach to this platform in introducing, one or two areas of collaboration, I think is a phenomenal starting place. I think where the point of weakness might have come is that this wasn't a negotiated pricing process. Neither the doctors nor the hospital groups were able to negotiate as a collective. And I think that there's so much work that's come out of the HMI, which was the Competition Commission's review. It was the Healthcare Market Inquiry that spoke to the appropriateness of return on investment, etc. And there's a way in which we could arrive at something that is more sustainable. So I do support that there is a role for greater collaboration going forward. Thank you for that.
Thank you, Melanie. Monica, if we can have a reaction from you on the issue of regulated collaboration.
Thank you, Chair. I think this particular point is exceedingly important. The use of reliable information, ongoing data collection, and shared system for communication within the sector are more necessary than ever before. I think when COVID first arrived in South Africa, everyone, including our medtech industry, rushed to kind of figure out which products and expertise were already available in the country, how best they could utilize them, and what additional resources were needed and where those could be located. The lack of data pointed out a huge vulnerability, and now we're working on implementing a very ambitious project to gather and track key medtech industry data. We recognize that there are short-term needs, and it's an indispensable application to have a unified healthcare system, such as the concept of the NHI that's been proposed. And I think, at the end of the day, without a collaborated intent on trying to engage all the stakeholders within the sector to be able to generate that very, very integral data, we may face more challenges in the future otherwise.
Yeah, thank you, Monica. Dr. Patel.
Yeah, definitely on price collaboration, I would have been happy if we had that in place for 15 years ago or so. But in general, collaboration always works, particularly in a healthcare environment where it's a social benefit and not necessarily a commodity on which we can try to make sort of profiteer or something like that. So I'm fully supportive. During this COVID, BHF has been out there, supporting a whole lot of efforts, also looking at the resources, the demands, etc., putting that together. Not just in South Africa, we've been helping our partners in the neighboring countries as well. If you recall, one of the decisions made in COVID kind of thing, where we blocked the export of essential medicines and PPEs, etc., that negatively affected our neighboring countries. So when we look at this collaboratively, we shouldn't just look at it in South Africa, in our private sector environment. We have to look at the whole of South Africa, but also broader than that. A lot of countries in the SADC region are dependent on this country and what happens and comes out of this country. So we need to look at it more broader than that in the collaboration as well. So yes, fully supportive.
Thank you, Dr. Patel. If we could then just reflect on what is not covered by the exemption that ought to have been included in the exemption for purposes of enabling the sector to respond meaningfully and effectively to the pandemic. If I can then start with you, Dr. Pillay, to weigh in on this. What could be done to improve the scope and the breadth of the exemption?
I have to say, in the experience thus far with COVID, I have not found an area of the exemption that hasn't been enabled by the legislation. I certainly think the exemptions were much broader than what we actually took advantage of in various sectors. And I think the opportunity to utilize other aspects of the exemption that have not been done as yet is what we need to pursue. I'm not aware of any obstacle of any of the legislation or regulations at this stage, and I think the exemption has been fairly adequate in this regard. But I will be advised by the other colleagues as to whether they have experienced any challenges. Thank you.
Thank you, Dr. Pillay. Melanie, is there anything else that ought to be included to enable collaboration among your members?
Thank you, Chair. And I'm also going to speak on behalf of the doctors at the same time, because I think it all falls within the same category. The area of the exemption that was most applicable here really related to coordinating to ensure that patients are allocated between hospitals in a more efficient way. It was really about communicating on capacity and utilization. And as a result, the tariffs that were tabled are not sustainable, and especially so for the doctors, where it thoroughly under-recovered to the extent that they, a lot of them just, offered to do the work pro bono. It was not sustainable. So I think the point of weakness here is that there needs to be appropriate discussion then on the pricing. So if other service lines need to be done, it needs to be done in a more sustainable fashion. So I think where you could strengthen the block exemption is the engagement on pricing.
Thank you, Melanie. Monica, you also made some observations initially, and it looks like there's been underutilization amongst your members of the scheme provided by the block exemption. So what could be done then going forward to improve the exemption? I think you have discussed the issue of communication as one of the issues that you encountered a challenge on.
Thank you, Chair. Yes, so I do think, we, from a SAMED's perspective, there was a level of collaboration within the industry regarding supply, talking to a very important part of the conversation, which was enabling local manufacturing to be improved within the country, given the extent of the limitations of supply from international existing suppliers. And I do think that the exemption itself could be communicated far more comprehensively. I think that's a better word. We would recommend that the Commission may consider, holding workshops or communicating a little bit more clearly as to regards to the intentions behind some of the methodologies behind the exemption. I think the key phrase within it, which I think which did cause some confusion within the information, was the reference to requiring that the exemption had to be undertaken at the request of the Department of Health in regards to this. And I think that as a key element was a concern in terms of driving the uncertainty amongst technology suppliers. And I do think that could be potentially improved upon.
Yeah, thank you, Monica. If we could then move on to Dr. Patel, what could be done to improve the exemptions framework?
From the legal perspective of the regulations, we don't see any problem with that. That type of framework, as I said, is an opportunity to build on from future and the recommendations of the health market inquiry. The problem we found were the players in the environment. For example, in the regulation, you had it quite clear that if something negotiation on price had to take place, you had to have the Department of Health's blessing and approval on that. But where was the Department of Health? If that's a function that was allocated to the department, the question is, were they, did they act proactively to create an environment for people to have discussed price? And my answer on that one would be emphatic no. And we understand why they were too busy with other stuff. So That's why we approached CMS to say, can you take on this responsibility? And unfortunately, that didn't take place. Another example where the player walked away from the table where we were discussing is the whole pre-admission testing and elective discussion. Unfortunately, when you create a voluntary environment, not everyone is obliged to sit around the table to sort out problems. So regulation, no problem. Players, yes, that's where the issue was.
Yeah, thank you, Dr. Patel. Jackie? Nandi, is Jackie still on the line?
Were fine. The issue came with the players. I mean, for us in the pharmacy environment, I think the response to the acquiring the procurement and the pricing of PPE was a huge issue for us. The market was flooded with sort of substandard PPE. Nobody knew where it was coming from, and I feel that perhaps the Department of Health could have done a bit more there. The B4SA, by the time they did procure PPE, the market had settled down. So that was one of the challenges we had. The other side was the collaboration between healthcare sector and the non-healthcare sector, and for us in particular, the property rental sector. So you'll know while the pharmacy sector was compelled to stay open and provide service to patients across the country as per the presidential request, the sector received very little help from the property rental. Small pharmacies were forced to continue paying rent in full. The corporate sector, in some cases, used their power to obtain large rental rebates from the sector. And I think the lesson here suggests that the corporate sector in health is better placed in terms of the power dynamics. And I think there could have been more assistance from there, but it wasn't the regulations, it was more, as Dr. Patel says, the plan. Thanks, Chair.
Yeah, thank you very much, Jackie. Perhaps at this stage, Nandi, we could open up the discussion to questions and to a questions and answer session. I'm not sure whether you have received any questions at this stage.
Thank you, Bake. Thank you for that very interesting discussion that you moderated there. It did bring up a number of questions, and we're going to go through them in a moment. And I'll go through the entire list, I think, just to make it a bit easier. And as I read, I'll direct the questions to the relevant people that the question has been asked of. Before I go into the Q&A, I do need to acknowledge Dr. Angelique Coetzee. She has joined as a member of the audience. Due to technical difficulties, she was unable to join as a member of the panel. I really must apologize for this. We were looking forward to her input. If we can still get her input in writing, then I'll be able to read it out. But let me just acknowledge that Dr. Angelique Coetzee, the National Chairperson of the South African Medical Association, is with us in the audience with some of her colleagues from SAMA as well. So perhaps let me now go through the questions, and I will, as I read them, I'll just allocate them to the relevant people. The first one is a question for Monica. Given the concerns raised by the members, how does Summit propose this could be refined to be effective? And then I'll move on to the next one. Monica, if you could just note it, and then when I'm done with everything, then please may you respond. There is another question that Dr. Pillay has already kindly responded to. Then we have a question from Anonymous. The funding industry hasn't been able to fully optimize on the exemption due to the fact that we need to work with the Department of Health. However, they've been overwhelmed. How can we work around this? Perhaps Dr. Patel or Dr. Pillay may be able to respond to that one, or perhaps both of you. The third question I'm going to direct to Bake. Can we, as the BHF, apply for an exemption around this? We've been waiting since April for a response from them. Perhaps Rajesh has a comment, and then I'm addressing the question though to Bake. Then we have a question from Nkululeko, who is asking, could there have been much better collaboration on all aspects contained in the block exemptions without a focus on the price of health goods or services? I think some of the panel members have partly addressed this question, but I'll put that one out for everybody to answer, all the panel members to answer. And then we have, Anban has already responded to another question here. Then we have finally a question from Heather Urban from Bowman's, and she's asking, did the Competition Commission receive any requests from companies to consider their proposed collaborations and give them formal or informal feedback on whether this would fall inside the exemption or not? Bake, I'll be directing that question to you. I do have another question here. Let me read it. Let me read it out to you. There's two of them. One is the Competition Act says that it doesn't apply to concerted conduct that's designed to achieve a non-commercial socio-economic objective or similar purpose. Could all the collaborations under COVID-19 have fallen under that exemption, if you will, in the Competition Act? And I'm directing that to Bake. Then the last one is there is a growing concept called a regulatory sandbox, where players in a market get to experiment on different products and innovations that are coming up without the burden of regulation, or at least a lot of regulation. This question is directed at Bake as well. Is it possible that this could apply in healthcare to enable more collaboration and better innovation? I'm trusting that all my panel members have their questions. Could I start with responses from you, Bake, please? Bokosbake, did you receive the questions?
Yes, I will respond in a moment. I was just setting up. Thank you, Thank you.
Thank you, over to you.
Yeah, in respect of the first question, Nandi, relating to the expansion of the exemption to cover the healthcare funders. There is an area of collaboration applicable to the healthcare funders in the exemption, and that relates to collaboration around the reduction of costs of diagnosis, tests, treatment, preventative measures, and the like. So there is a limited exemption there that is applicable to healthcare funders. That is focused on cost reduction. To the extent that there was a request from the Board of Healthcare Funders for the expansion of the exemptions, those engagements I think have happened between the board as well as the Commission. I think the overriding principle is that at this stage, any collaboration that is exempted in terms of this framework must be a collaboration that is responsive to COVID-19. Any other collaboration that is not responsive to COVID-19 will not enjoy an exemption under this scheme. Hence, a need for a broader discussion about collaboration post COVID-19, which is a much more broader discussion. In respect of other companies which have approached us, as well as the ministry, for an exemption, I think in respect of COVID specific requests for exemptions, both the Commission as well as the ministry have been quite responsive to those requests for exemptions. But those exemptions, I think the overriding principle again is that those requests for exemptions must be responsive to the crisis. So where a request was not responsive to a crisis, unfortunately, it could not be entertained within the framework of Section 1010. So in respect of the question relating to whether what has been sought to be exempted in terms of this block exemption could fall under a non-commercial socio-economic objective, I don't think so, because there is of course a commercial element to this. And what the exemption simply seeks to do is to ensure that the response to the crisis does not result in a situation where, especially in a crisis such as this one, where health care is not affordable. But I don't think that we can say that the commercial element is suspended. I think it's there. So it is, the last question was whether it is possible, to, as I understood it, if I understood it correctly, Nandi, is whether it is possible to have broader collaboration on healthcare. I think it is possible, and I think what is clearly emerging is that COVID-19 is going to reshape how we think about a number of things, a number of issues. It's going to reshape how we think about macroeconomics. It's going to reshape how we think about competition economics. It's also going to reshape how we think about competition, in particular competition, for instance, in the healthcare sector. So that is an inevitable outcome of a crisis. They tend to reshape thinking and societies post the crisis. So we will definitely have to rethink and reflect of how we have viewed competition as well as collaboration in the healthcare sector in general. So that outcome is definitely inevitable. Thank you, Nandi.
Thank you, Bake. Can I move over to Monica? Given the concerns raised by the members, how does SAMET propose this could be refined to be effective?
Thanks so much for the question, Nandi. So I think, we would probably make the recommendation that it would be useful to hold workshops with the parties or industry sectors that the exemption applied to, and consider including key stakeholders such as SAPRA, who is the regulator for health products in South Africa, and that way suppliers could engage with the Commission and clarify any questions they may have had. SAMET itself provides our membership with frequent training and updates on the Competition Act. So it could be also that our suppliers may have been wary of contravening competition law and were uncertain as to how to go about utilizing the block exemption. In our experience, implementation of official government documents or notices and regulations, it's always in the interpretation and the practical implementation of these documents. And that's why our recommendation would be to consider having potentially a workshop with the Commission to understand the context and the purpose and make themselves available to answer questions, which would be ultimately very helpful for suppliers within the sector.
You muted, Nandi.
Thank you. I'm sorry for that. Thank you, Monica. Can I move over to Dr. Patel? There were some questions related to the funding industry. The funding industry hasn't been able to fully optimize on the exemption due to the fact that we need to work with the Department of Health. However, they've been overwhelmed. How can we work around this? And I'm also going to ask Dr. Pillay to weigh in on that question. And I thought perhaps, Dr. Patel, you might have a comment on a question from the audience, which is, Can we as the BHF apply for an exemption around this? We've been waiting since April for a response. And after you, I'll go to Dr. Pillay.
Yeah, I think I'll tackle both these questions in one kind of thing. I think definitely the Department of Health has been overwhelmed, and I think it's important for them to play a role in looking after the public and making sure the COVID disease managed properly. To worry about pricing in the private sector, etc., I think it's an additional responsibility that they can probably do without. And it's on that basis that in the initial stages we felt CMS to be an ideal candidate, because right in the beginning of COVID, it was a novel disease, declared a notifiable disease. In some or the other, we had to make sure that the funders came on board and had a package of benefits that was made available. And we worked closely with the CMS, and I know BHF fully supported the benefit package that was proposed initially. We're fully supportive of the testing, and we weren't afraid of the risk and abuse, etc., of the over-testing, etc., in that environment. And it is because in those early stages of this COVID epidemic that where the industry and the CMS worked very closely together to try to set standards, etc., and bring the funding industry on board, we felt that they were probably the ideal candidates instead of the Department of Health to run with this. But we understand the regulation says the National Department had to be on board. So working with the CMS, we created a framework, etc., which the CMS had to take to DOH, get it rubber stamped between the Department of Health Minister, etc., and we would have been able to run with this. Unfortunately, and that happened all in April, till now, we haven't had a single reply. So in the absence of a regulator who should actually have been proactive and driven the 9 million lives and ensuring that the 9 million lives, their needs were met by this regular CMS, obviously nothing happened. My view is from a pricing perspective, perhaps an alternative solution might be to work with Nicholas Crisp and his department, particularly because with them establishing an NHI, we from the funding side, we have mutual interest kind of thing, not just for the short term, but it could be the stepping stone for a longer term solution for both the public-private sector. And I think to me, that's an alternative that we need to consider. And obviously with Anbin at the table here, we hope that one of these two can be fast-tracked and that we can go ahead and put on some solutions that will help us for the future. Thank you.
Thank you, Dr. Patel. I want to move on to Dr. Pillay, but I'd like to add two other issues that have been raised, Dr. Pillay, for you to address all together. The first is there was confusion regarding the requirement that the Department of Health would approach healthcare stakeholders, and this hindered stakeholders from being proactive. Some healthcare funders were, for instance, not sure how to approach healthcare service providers without the facilitation of Department of Health. We would really appreciate clarity on this. The second one, Dr. Pillay, is not all practitioners were included, only specialists, example, GPs not, physiotherapists not included. Was this intentional or was it an oversight? This increased the uncertainties of what was allowed. Just want to check, Dr. Pillay, if there's anything else I can address to you before you respond. Please go ahead, Dr. Pillay.
Thank you. Thanks for the questions. Let me see if I can deal with all of them. On the question relating to the funding industry, I think it's important to understand the context as we understood it, is that the exemption was to try and facilitate the response to COVID, both in the public and the private health system. In terms of the funding industry and the concerns that the funding industry has, I think those issues would probably best be discussed with ourselves as well as the regulator. I'm not aware of exactly what the issues are between the regulator and the funding industry, but maybe we need to be brought on board so that we can understand this more deeply so we can respond appropriately. There was a question, I think it was from Nkululeko, around the issues of collaboration other than pricing. You'll notice that there's a preoccupation around pricing, but there are many other issues that there could be collaboration on. The one is clinical guidelines. So there are clinical practice guidelines, for example, in COVID that we've been putting out, and collaboration around that would be important. Around issues of human resources and how they being utilized and managed would be another area. Around the issues of PPE, I don't know if people are familiar with this, but the PPE in the country is not regulated formally like the way medicines are regulated. And so you would anticipate that between the public and the private health system, that we'd all be interested in making sure that we buy PPE of appropriate quality. And where there is poor quality PPE in the market, we should collectively then eradicate that, because that causes great harm to the healthcare practitioners that use them when they're substandard. And I think that's another area that we need to collaborate on. Similarly, on the issue of equipment, there's equipment that fits into the same category that would need collaboration so that we can collectively buy good quality equipment. While the regulator, I think SAHPRA has this in their mandate, I think they just haven't got down to regulating these products to the extent that we would like. But even in the most developed markets, you'll notice that during COVID, they have battled to get good quality product for a variety of reasons. And I think we need to see how we can deal with that. I think with the question relating to approaching stakeholders, our request to the Commission when we were dealing with the issue of COVID is we wanted to collaborate on a public health response. And so where we believed that there were gaps in the system, where we need to go in and fix those gaps, we approached particular stakeholders to deal with that. And I think the biggest area where we had weaknesses was in the area of hospitalization, access to hospital beds, ventilators, etc. And so that led us to have collaboration with the private hospitals, as well as with the private pathology groups on the issues of testing, etc. So the approaches to the other groupings that may have been part of the exemption was linked to whether we thought there was a need for a particular service or not as a public health response. Where we didn't see a crisis, we obviously didn't pursue any particular discussion in that area. So I think from our side, we would anticipate that this exemption is intended to deal with the issues of COVID and where there are weaknesses in the current system, and the exemptions are meant to fix that. I think on the issues of collaboration and engagement around the issues of pricing, remember the Competition Commission did an entire document on that, on how the issues of pricing must be dealt with in the private sector. And I think those recommendations we need to pursue using different approaches to what we're doing here. This is just a quick fix to a crisis that arose affecting the country. Once we get over this, we will then pursue that recommendation and set up the appropriate structures to do that. I think using this exemption for that purpose would not be appropriate as well. Thank you. Thank you very much.
Thank you, Dr. Pillay, for that comprehensive response. I do understand that Dr. Angelique Coetzee is now able to address this forum. Could I hand over to you, Bake, to address her directly?
Thank you very much, Nandi. Dr. Coetzee, are you able to hear us?
Yes, can you hear me, Bake?
Yes, I can hear you. Thank you very much. Apologies for the technical glitches.
No, that's accepted. From SAMA's side, thank you for inviting us. I'm going to be brief in the interest of time, and a lot of things that was said we do also agree with. Very important from SAMA's side on this, as Dr. Pillay also now referred to, that it was a quick fix for COVID. It was a very limited set of agreements that could be reached, and under this exemption, we also not very happy. We understood that the service level agreements could not be negotiated nor discussed with the association members, and much of the clinical discussions and coordination should actually happen. It must happen. So the question arises: should there really be an exemption from the Competitioners Commission on the clinical collaboration, where we share data, standardized quality of care protocols, communicate with each other, and help with medical supplies and equipment? You know, one needs to look at that. Is very important going forward. I'm not going to go into the SLAs in detail because we know it was not really negotiated with the doctors. It came between the National Department of Health and the HASA. Again, from us, what enabled the practitioners, very important on the PPE coordination. In this case, we can see how collaboration with Business for South Africa, they negotiate and purchase the PPEs, they negotiate, and that was given through to the practitioners. The clinical coordination, how important it is to have discuss the GPs versus the specialists' role in managing patients. Also the clinical meetings with the Department of Health to discuss clinical roles. Then on have the provisions been practical to us? Yes, coordination has been improved, but again, we believe from the professional imperative to work together in the face of a disaster, and not because of the Competitioners Commission's exemption, not to allow a negotiation of prices or services, or to discuss prices very wildly with practitioners with some of the challenges that we saw, and the difficulty to propose a set of services without being able to offer a price or negotiate from our side on these. The shortcomings, again, the ability to negotiate prices and tariffs. The aspect of medical negligence will not address, a very important aspect. Clinical coding issues was also not explicitly addressed in here. And then again, what do we learn? That the members of the healthcare sector need to be able to collaborate. This is the only way we can better facilitate care and coordinate the whole healthcare system. Where the exemption has not been very useful is it shows us as well that the practitioners' environment is very fragmented. It's difficult to get the parties together, even under emergency situations. Again, it was unclear to whom the exemptions applied, and there was still too little room to define a service and offer it for a cost. And clinical collaboration and sharing of clinical information happens in any way, and it must happen. So please, this is from SAMA's side in a very nutshell.
Yeah, thank you for those observations, Dr. Kotsien. Thank you very much. Nandi, do you still have more questions?
No, Baki, I think we can move over to concluding remarks.
All right, thank you very much, Nandi. I think we will start once again with Dr. Pillay. If you could just conclude on what should be the way forward.
Thank you. Thanks for the opportunity to provide some closing remarks. I think this was a useful session to get a sense from all parties about how they felt about the exemption. I think this was a very quick response to a crisis that we faced, and we tried to respond the best we can. And I think the Commission had done the same. And so I'd like to firstly just appreciate the work that you did to allow this to happen. I think from our side, the exemptions were adequate from a regulatory perspective. I think there were aspects of it that we could have implemented better. In hindsight, this is always, the perfect science. But I think we did well in terms of what we've been able to achieve with the exemptions that we had. I do think we can use some of the experiences from the exemption in order to inform how we take the broader negotiations and collaboration between providers, between the public and the private sector forward in a more effective manner. And I think we should continue to have those discussions so that we can share those experiences and shape the future so that we learn from the lessons of the past. But I think in the context we've done well. I do think that there's an opportunity for other areas of exemption, but we should take these in the same approach that you've done this one, small pilot projects or sandboxes, as Nandi called it, and see how we take that forward. Thank you.
Yeah, thank you very much, Dr. P.A. Melanie.
Thank you, Chair. And I didn't have an opportunity to comment on the previous question, so I'll try and wrap it into one. So yes, this was a quick fix in a crisis, and I think we've all got to appreciate that we're writing this textbook as we go along. This is all new terrain. I did, however, feel that the comment with respect to preoccupation on pricing was a little bit unwarranted, because I think, credit where credit is due. We saw private sector doctors and facilities step up to the plate, notwithstanding unilateral pricing that was below cost. And I just want to thank everyone that has done that, and we saw a significant spirit of Ubuntu. I think that what we're referring to, Chair, when you speak of a regulated process here, is specific to state patients. And the HMI hasn't covered that. But even with respect to state patients in this process, you must understand, we needed to remain fully staffed and keep doors open. And we did that notwithstanding the liquidity crunches, as you saw health practices fall by 50 to 70%, especially during lockdown levels 5 and 4. But notwithstanding, everyone really stepped up to the plate. So I think credit where credit is due, a phenomenal process, a lot of lessons learned, and a lot of great relationships cemented, not just at a national level, but especially at a provincial level. So, thank you to everyone that participated with open hearts, as they have. Thank you.
Thank you very much, Melanie. Monica?
Thank you, Chair. So I think from Samed's perspective, I think, there's been a lot of talk during all the comments, the Q&A, and during the feedback sessions, that regarding particularly the comments regarding quality of medical products within that were utilized during the COVID pandemic, specifically referencing things like PPE and things like that. I think South Africa needs better resourced and more agile, properly capacitated, implemented medtech regulatory and procurement systems across both the public and the private healthcare sector. At any time, and especially in a pandemic, we need to have an agile and a very responsive regulatory and procurement pathways that will allow the industry to be able to better manage and deal with and address the challenges that we were facing. Samed advocates that the health department and the private sector entities adopt international best practices that allow for smart, transparent, and value-based procurement of medtech. As an industry association, we've produced a lot of very valuable and widely available information and checklists to facilitate the adoption of this approach. Because I think when we make a mistake of focusing solely on price and forgetting about the aspect and the importance of quality, particularly with the medical devices, you land up with some of the problems which unfortunately we have seen within the environment at the moment, which have had a very negative impact on both on patients and healthcare professionals at the end of the day. Appropriate and agile medtech regulation procurement are crucial to quality health services, but they're very complex, partly due to the diversity of the types and application of these devices and the technology within the sector. Samed continuously engages with SAHPRA, with procurement and supply chain managers, medical technology suppliers, and healthcare practitioners to strengthen the regulatory and procurement capacity within the South African environment. But at the end of the day, I think we need more education for all the organizations and individuals involved in the supply of medtech in order to prevent the challenges that we've recently witnessed, unfortunately, within the sector. So, at the end of the day, I think the intention behind the healthcare block exemption was outstanding. But there needs to be a lot more intricacy involved, and I think the stakeholder engagement has to be imperative within the give of those functions. Thank you so much.
Yeah, thank you very much, Monica. Dr. Patel.
Thank you very much. I never thought I'll compliment the Competition Commission for the Health Market Inquiry in this event. I think this has opened a lot of eyes and resulted in good engagement. I definitely want to thank you for this discussion, clarifying certain things as well for us. Anban, I will definitely take up your offer of engaging with you on obviously the problems that we're having in the environment and the solutions that's still needed for the industry. Dr. Angelique Coetzee comments that highlights the issues of PPEs, pricing, etc. is still valid, and I think there's a need for solving some of these issues around. The issues are not just pricing only, they also relate to guidelines issues and the gaps in the guidelines that are out there. We definitely want to engage further on that too, so that we can plug those gaps. And I think going forward, COVID is not finished, so this regulation is still appropriate. We'd like to obviously have it expanded, not just to COVID, but beyond COVID as well, to a whole lot of other things. And really, if we can, instead of deal with it in an isolated way, let's try to deal with it broadly so we can start bringing in the solutions that we need for NHI as well. We can start doing it from now. Thanks a lot. Thank you very much. Thanks for the opportunity.
Thank you, Dr. Patel. Jackie?
Thanks, Chair. So I think for me and the pharmacy sector, I think we didn't fully utilize all of the benefits that the exemption offered. I think we certainly needed or could have or still can collaborate better, for instance, with the clinicians, with the funders. I think there's a lot more room for collaboration there. I think that the relaxation of the certain restrictions can actually benefit the end users of our products and services, and that's mainly the patient. And I think this COVID pandemic has really opened the door as to what we can do when we collaborate. And for me, it's given a glimpse of what NHI will be like, where we will be collaborating. I want to thank Dr. Pillay Anban, that certainly the National Department of Health, as much as they were in crisis, they always made us feel included, gave us a lot of support. I think manufacturers and wholesalers working in silos pre the COVID has led to artificial medicine shortages and or stockpiling of medicines. And I think that going forward, we really need a more transparent supply chain, a more transparent collaborative framework for all of us to work in, always with the patient at the center. And I want to thank the Competition Commission for hosting this. I think it's given us a lot of clarity and shown us that there's still many more advantages to this block exemption that we can utilize to better afford care to the patients out there. So thank you from ICPA.
Yeah, thank you very much, Jackie. Dr. Coetzee?
I believe Dr. Coetzee is no longer available. Baki, I think that she wrapped up her comments in the last her last talk.
Oh, thank you very much. I think then that brings us to the end of the panel discussion. Maybe before I hand over to Nandi, thank you very much, fellow panelists. I think you have provided quite illuminating and quite helpful insights. Thank you, Nandi.
Thank you, Baki. And I also want to say thank you to all of our panelists and the audience participation. I want to say thank you to Dr. Patel for the compliment. We will take whatever we can get from the BHF. There's certainly a lot of room for collaboration. I hear from everybody. I think the next collaboration should be the Jerusalem Challenge for all of our healthcare practitioners and the Competition Commission. Let's just come together and do this thing. But thank you everybody for your participation. The conversation doesn't end here, and we do hope in the spirit of collaboration we'll continue to talk and continue to come up with solutions for the industry. Thank you.